Yeah, actually, I wrote a couple of questions down for our presenters.
I think everyone is here except for maybe Dr. Lilly and Dr. O'Hare. Not sure if he's still here, but
I thought it was really interesting to hear about the various limits that we can pass now. My question for you, actually, first, is when you do the PFO, LAA occlusion, what guide do you use to get into the?
yeah, so I've done this maybe about 20 times now, so again, I want to highlight a very small number of cases. But what I learned after the first 3 cases, that I almost consistently require the use of a single curve sheath instead of a double curve. And I'm always aiming for either, sort of a straight neutral lobe or posterior lobe. I've used an anterior curve sheath a couple of times, and I almost never use a double curve if I know I'm going to do that. I can only think of one case where I had to do a partial recapture. But really, I mean, I don't know if it's just luck or what, but I've been able to get in and out without having to make a second hole. And, it seems to me like it's a natural thing to try. One potential approach would be to try it. If you're having trouble getting your guide to get into the LA, abandon and come out and make a separate puncture. But I think it's something worth looking into, and certainly it's hard to get a pericardial effusion from a transeptal puncture gone wrong if you go through a PFO.
Are there any particular questions from the audience? Otherwise, I have a few more.
Any other comments? Anything to highlight? I think we saw incredible presentations today on a lot of different aspects of not only left atrial appendage, but also PFO and atrial shunts. So thank you to all the presenters. I think I'll just kind of make one comment and maybe open it up for a brief discussion. But one of the challenges that I find in my valve clinic is that the consults that I see for left atrial appendage closure with the Watchman are often the more time-intensive consults compared to TAVR or MitraClip. If there are others in the audience that want to chime in, please do so. But these are the consultation visits where there's a lot of discussion, there's a lot of questions from the patient about do they need this, and I often make it a point to highlight that the Watchman device is not obviously going to make them feel better in terms of their physical symptoms of their actual organic disease issues. It's mainly to protect them obviously from the risk of stroke and protect them from the risk of bleeding related to their AFib. But these are time-intensive consults, and yet we have presentations today on so many advanced areas of LAA therapy, but kind of bringing it down to the most basic level, being able to talk to your patient about the merits of LAA closure, and the indications and whether they're appropriate for it is paramount before considering some of these more advanced topics that we've talked about today. So any comments on that or anything else anyone would like to mention? Yes.
What do we know about the AtriClip when people go in, have some surgery on AtriClip? Do we have any follow-up on those? Any surgical data? What does their follow-up look like on AtriClip patients? And second, when you see some flow around the device, when you do appendage occlusion percutaneously, when is you say, okay, I think it's small, let's take her off the anticoagulation, or no, I'm uncomfortable, this was not that great?
Yeah, I'm sorry, what was the AtriClip question? I didn't hear you.
Is there any significant data that we can compare to Watchman versus AtriClip? I know there's a small series about AtriClip, but nothing randomized.
Comparing AtriClip to Watchman? I'm not aware of any data comparing those two. I don't know if anyone else is, but I can think of maybe one patient in the last 5 years that I referred for AtriClip because Watchman was thought not to be technically feasible, or they were not able to take oral anticoagulation or antithrombotic therapy at all afterwards. The Lariat device is also one that could be considered in those scenarios as a compassionate use device. If patients are truly not able to take anything at all, but I'm not aware of any comparison to AtriClip with Watchman. Any other questions? Yes.
I just make a comment on your comments, and I think that number one, you can't do this properly in 20 minutes or 25 minutes. I think you're kidding yourselves. I tried to get at that in terms of these are complex patients, they're complex issues, And it's much more complicated than just, you know, here's your CHADS-VAS score, and you know, you're at high-risk bleeder, so let's just kind of do it. I mean, you really have to spend time understanding what the patient's risk-benefit is. And we do poorly at that. I mean, we really do poorly at it. Are they going to bleed again or not? I have no idea, you know, and you have to have that discussion. And so my kind of technique of door number 1, door number 2, door number 3, you have to talk about, well, if you're not going to do anything, this is what's going to happen. If you're going to do anticoagulation, this is what's going to happen. And if you do the device, this is what's going to happen, and the pros and cons of it. And you can't do that in a short period of time. So we need to develop better tools, better mechanisms to do that. But if it's done well, I think it works great. The other thing is the device-related thrombus issue that I struggle with. I tell my patients, actually, I spend a fair bit of time on that issue, not because I think it's a big issue. I personally don't think it's a big issue. I don't think there's an association. There's no doubt about it. That's been proven. But I'm not so sure it's a direct effect. That thrombus that was sitting there for 10 years probably, that I don't think they break loose and go places. Personally, I think what we're dealing with is an association, that these are higher risk patients, and the higher risk patients with stasis will develop thrombus, but they're higher risk anyway, so that's probably what's going on here. It's an association, not a direct effect. But you have to tell your patients that that's going to happen, because when it does happen, everybody freaks out, and then it's like, oh, you did this whole thing to avoid anticoagulation, and you're committed to having to start anticoagulation again. So I spend a lot of time being very specific about that small risk, so that when it does happen, and if it does happen, patients understand why that is. So just a couple comments.
Paul, any comments? No.
Thank you. I have a comment. So, you know, Mario, you gave the talk on anticoagulants after Watchman. I think in my practice, that's been my biggest challenge. You know, a fair amount of my patients are bleeders, and not 1, not 2, not 3 patients I've seen where we follow the routine post-procedural protocol, put them on anticoagulation, and 2 weeks down the road, they're back with a GI bleed. You know, being able to go to something simpler, maybe DAPT or single therapy, would be really, really useful in this arena. I think that, you know, using an anticoagulant following Watchman is really tricky. The second comment is, you know, I've seen a few patients now where they've had a Watchman and they come in with AFib, and, you know, my partners call me and say, hey, I want to cardioverse this patient. What should I do? They've got a Watchman in place. Should I put them on an anticoagulant after cardioversion? What should we do? You know, I don't really have a good answer for that. Sometimes I say, well, they've got a Watchman. It should be safe. Go ahead and cardioverse and continue their current medical regimen. But I don't know if anybody has had these issues or challenges where how you manage a patient that needs cardioversion after Watchman implantation.
Yeah, it's a great question. I've had that issue 3 times, and as far as someone who has a Watchman device and has to come in for cardioversion, all 3 of those patients had already completed their 6-month post-implant course. And I asked the colleague to just go ahead and do cardioversion and not do any anticoagulant afterwards, and this was probably in the last 6 months, and they're all still doing fine without any issues. Now, if that had occurred, if that same scenario had occurred within the 45-day period or within the 4.5-month DAPT period that follows, obviously I would just continue what they were already on. But outside the 6 months, I think it's okay. It should be reasonable to not have to give them anything extra for that. As far as the first comment you made regarding the challenge with keeping them on 45 days of an oral anticoagulant, and Mario, please also chime in on this, but you know, I've gone to, I would say, almost 50% of my patients post-implant are getting DAPT based on 6 months DAPT based on evolution data. And the challenge there is that I've enrolled several patients in ASAP2, and speaking with patients candidly about the merits of participating in an important research trial where they would have the option of being randomized to nothing, no Watchman, versus a Watchman with 3 months of DAPT. The most common question that patients will ask is, well, why wouldn't you just put a Watchman in me commercially and give me 6 months of DAPT? And that's a challenging question or challenging scenario to handle, and that kind of highlights the first point that was made. Yeah, thank you. That highlights the first point that was made about the fact that it takes time to talk to patients about Watchman research trials. If it takes time to talk to them about a commercial Watchman, it takes twice as much time to talk to them about Watchman research trials. So if you have ASAP2 at your site and you're trying to be a high enroller in ASAP2, or you have the option trial or Watch TAVR, you're going to spend even more time talking to your patients about these nuances. So it gets really tricky, but I would say, the evolution data is pretty good. I think we can get some solace to use DAP for 6 months in post-Watchman implant patients if they can't tolerate a NOAC or a DOAC, or if they have a bleed 2 weeks later, like you mentioned. And, to my knowledge, those patients have done very well, not only in that registry, but in my practice, I haven't had any issues of DRT or anything like that in those patients. So I think it's pretty safe. But the ASAP2 trial is a very important study. So those of you that are enrolling in it, I think it's going to be interesting to see what we find. So I don't know, Mario, if you have any other thoughts.
Question for Didi, because Didi is here, should pick her brain. 2 questions for you. One is, you are an expert imager, we have expert imagers, but eventually we're making recommendations for for everybody, right? So we always talk about learning curve for interventional cardiologists, what they have to learn and what they have to do great eyes and all that. So number one is, what is the learning curve for a CT imager? What do they have to learn in order to provide actually the data that you present? Because not everybody, I think, in a radiology department or even a cardiology radiology can do that. And number 2, what I struggle with is when I listen to the talks, CT, and it tells me how deep it is and how deep I can go. Well, the truth of the matter happens when you are actually inside the LA. And are you then pushing further and harder because someone told you you can? Or are you still limited to the fact that you don't want to push harder because your pigtail just doesn't go where your CT reader told you to go?
So great question. The first question was, what is your early operator learning curve for the imager? And the second question is, when is the imager correct in putting the implanter at risk of a perforation for LAA closure by saying go deeper? So for the first question, anybody can do imaging for a structural intervention or transcatheter intervention. The main problem is if your imager is sitting in a different room from the implanter, they're of no value to the team. The imager must be an integral person on the team, and the imager must be with the implanter when analyzing this. If the imager does not go to the training for the LAA device or the TAVR device, they don't know the nuances that the implanter has to learn, and they don't understand the liability. So an imager that is going to be helpful to an implanter has to be equally invested and actually has to be equally liable to understand the problems. Otherwise, they can do whatever they want to, and they will never give the implanter the confidence they need for the procedure. The early learning curve for the LAA CTs in an imager who learns with an implanter is probably about 15 to 25 CTs. After 25 CTs, they've seen pretty much every single nuance, and they've hit the 80%. Together from there is like the mitral clip. They had to learn together with the implanter. But 25 is plenty. And we've published on that for the interventions. For how deep do you go, we can always give you a length, but we don't want the LAA device feet to be caught in the distal LAA, because then the device, no matter how good the landing zone is, it will never open up or inflate to what you want it to be. For that situation, you can always do device testing with a 3D print or a 3D model. Or the other thing is we actually cheat the feet, so we don't push. We cheat the feet when we actually load the device, because you have a millimeter extra of plastic on the distal catheter. And when we cheat the feet, we know we're doing it. And we actually have off-label use of the device to know what the cheat the feet is for every single device. So to do that, though, again, in the first 25 cases, you'll learn what it is. And the projection, Chad has shown amazing pictures that we always get jealous of that look beautiful, how you can do the fusion. If you don't have the fusion, you can figure out, well, what is your width? And it's usually you want to have at least 2/3 width in the distal LAA for what your maximal landing zone is going to be, so that you won't get your distal feet caught. Does that answer your questions?
Chad, I have a question for you. You showed beautiful pictures of fusion imaging for LAA. Tell me, in your experience, how much time, if any, does that add to your Watchman case day? Are you able to do 4, 5, 6 cases in a day with aggressive use of fusion imaging for each case, or are you just sort of using it appropriately for certain cases where the anatomy is more challenging and maybe scheduling less cases on that day? I mean, how do you logistically handle that?
So I do think a key thing to this, and even for the pre-procedural evaluation for the CAT scan, is it's not a radiologist or cardiologist reading a scan and printing a report, and you looking at the report and then deciding what the Watchman size is or device size is to implant. It's really key that the imager and the interventionalist look at the imaging together. And I think you can ascertain really good data from the CT scan. You can see the entire shape of the appendage, all of the lobes, and really visualize so that there's no question in terms of in a 3D space and in a reconstruction model, and then in your head, that when you walk into the room, you know which lobe you're going to go after and the direction that the sheath is going to need to take. If you know your view, like we do for TAVR, it's very simple. I mean, we know our views when we walk in the room, and it's so planned out for TAVR procedures that it shocks me that the same is not happening for something like a left atrial appendage. So I think it's key that you can really step-by-step plan out size of the device, how you're going to get the device in the appendage to depth, and your optimal view. So really it simplifies the procedure a lot. And as I teach this, and my fellows do the left atrial appendage closures very quickly in the training because everything is sort of laid out very easily. In terms of the fusion imaging, the CT scan, Philips has a protocol as well as Siemens in order to segment the model of the heart. Unfortunately, Siemens, which is the system that I predominantly use right now, you actually have to change the segmentation. You have to model a little bit. So you have to make some adjustments, which does take a little time. In terms of workflow in the room, it's very simple. So once you create that segmented model, everything then happens in the room. For echo fusion imaging, this is done by the echocardiographer. So the echocardiographer imaging specialist in the room will set up the landmarks, landing zone, and then it automatically overlays register to the echo probe. So I think from a simplicity's sake, the technologies are advancing. It does add a little bit more time, and I think if you do it regularly on all of your cases, the workflow and the time gets even less. But I think it's an additive tool. I mean, it's funny how we've seen, 5 years ago when we were implanting these devices, that we would take a marker, and really we're marking on our $2 million room with our X-ray machine, and now we don't take the marker anymore.
Any comments? Yes.
A lot of smoke in the atrium and smoke in the appendage. Even on delayed phase imaging on CTA, sometimes it's hard to tell whether or not there's thrombus in that appendage. How do you resolve those cases?
So the question is, how do we use CT to rule out thrombus? The easy answer is you don't use CT to rule out thrombus because you're going to be doing a TEE on the table no matter what right now by current DFU, unless you're using ICE to look for thrombus. The one thing that we do is we use a retrospective analysis. So retrospective analysis, just like a TAVR CT, we gate the CT so we can see the LAA contractility. And if you read echo, you'll know when it's smoke and when it's not actually a formalized clot. It's also implanter confidence. An implanter might not feel comfortable implanting in a case where there's a lot of smoke in the appendage, whereas another implanter might be comfortable regarding that. When you call it the kind of thrombus that you saw on device-related thrombus, that's a no-brainer. But delayed phasing is recommended if you're going to exclude on the table TEE, but then you would have the time of CT to be right within the peri-procedural time of 24 hours when you can turn the heparin off to put the device in. The recommendations are coming out in a paper in JACC Interventions later on this year for a CT consensus document. So if you want to rule out thrombus, use delayed retrospective acquisition, contractility, look for smoke. If you don't want to rule out thrombus and want to get device sizing and projections, you can do prospective and do on-the-table TEE because you're still going to do TEE on the table.
Any other questions or comments? I think we need to be wrapping it up then. Mario, any other further comments?
Maybe one.
Sure.
Because of the holes that we create. So it seems, at least for us, when we try to recruit patients now with HFpEF or heart failure with preserved ejection fraction to these trials, it turns out that the people that we think have it, based on the inclusion criteria, don't have it. So the inclusion criteria are very strict to get a patient enrolled into an interatrial shunt. At least, we have that struggle. Does anybody have the same struggle? And what do you expect to happen? In commercialization, we're just going to implant them in more people then? I'm a little, struggled by the, shunting idea, and then we can't enroll them because eventually they really don't have HFpEF or not by the criteria that are used.
Yeah, I personally have not had an experience with atrial shunt devices or trials, but I don't know if there's anyone in the room that wants to comment on Mario's thoughts there. My understanding is similar to yours. Those trials are difficult to enroll in, and then the commercial applicability of the concept is a whole other challenge. Let me just mention, please come support the challenging case competition today at 12:15. The top cases will compete for a prize of $1,000 and earn an invitation to be faculty at CVI next year. Also, you will receive an email with instructions on how to claim CME, that's basically it. So I want to thank you all for being here today. I think this was a fantastic session. Thank you to all of our presenters. Excellent talks by everyone. Thank you.